She is the facilitator of the EMDR. I am the patient in the EMDR. We'll talk about that later today, but Jen is also going to talk about virtual EMDR, which she participates in. I don't do virtual EMDR. I just haven't learned that. So I only do EMDR in person. But Jennifer and another one of our therapists here, Linda, have done some additional training so that they're very comfortable and competent to do EMDR virtually, which is important in this COVID world. And so she's going to talk a little bit about that experience too. So let me just say with EMDR, myself, Jennifer Oakes, who you're going to see in the video later today, and Linda Hicks, who is another one of our therapists here at JP Counseling, we have all had 80 hours of training in EMDR through the Institute for Creative Mindfulness, which is out of Boardman, Ohio. And they are EMDR experts there. Jamie Marich is the leader there. Amber Bodner-Stiles is one of their teachers. And so we've had a lot of training. In addition to the 80 hours of training in EMDR, we've each had at least 10 hours of individual or group supervision specifically around EMDR at a minimum, and then additional supervision after that. So now, the good thing about EMDR is you don't need to do 80 hours of training in order to benefit from some of the techniques with EMDR. So we'll talk about that a little bit as we go, but it really does help you feel more comfortable to be able to get all that good training, because if you're a talk therapist, like I have been trained to be, then you tend to talk and have your clients talk, and EMDR moves away from that a little bit. So it's definitely a different technique. So that's kind of our plan for today. Glad that you guys are all here. Some of you may have had some experience with EMDR, and some of this may be entirely new for you. So we'll just kind of cover it as we go along. We'll deal with it. So to get started, those of you who are with me usually know that I usually ask you just at the beginning of trainings just to take a breath. I know that everybody is working really, really hard out there, and sometimes we don't stop to take care of ourselves. The other reason I ask you to breathe specifically today is because we're going to talk about trauma. We're going to talk about trauma in the context of the world and of clients and things like that. However, when the topic of trauma comes up, sometimes it does touch things inside of us. And so just, breathe through that. If anything does get a little too heavy today, then feel free to mute me and not pay attention for a few minutes to get yourself together, and just breathe through it. It's real important we take care of ourselves. So quickly, a moment of reflection, just thinking about the times that we're in, because we do need to think about EMDR today in the context of what's going on in the current world. So we want to remember that what's going on in our world right now is very unprecedented and traumatic in a lot of different ways. So, life in general sometimes is that way, but with COVID and the pandemic and some of the social justice issues we've been dealing with, there's a lot of turmoil going on that people are experiencing. So I like to just point out that each of you are responsible for a lot of things in the world right now. You're responsible to take care of yourself and your own family. You're responsible for your coworkers, for your clients, and just for the world at large. That's a lot of responsibility. So if no one has told you lately how much that is appreciated and how much we celebrate the work that you're doing, then I would like to be that person today to say that it is much appreciated. A couple things in the sense of COVID. Now, these are our most recent statistics that the American Psychological Association has come out with. So these are parent versus non-parent average reported stress levels during the past month related to the coronavirus. So you can see that the parents are a little higher than the non-parents, but not by much. So everyone is dealing with stress, and about at least half of the parents, 46% anyway, say that their stress level related to the coronavirus pandemic is high. So they rate it on a 10-point scale of at least 8, 9, or 10. And so that's pretty stressful, right? That's pretty traumatic. And trauma, as we will learn, is kind of like pain. When you first deal with it, you can kind of like push through it. Like, I got this. It's like labor. If for the ladies out there who've given birth, it's like you go into labor and you're like, I can do it. I can do it. And then after like 24 hours, you're like, holy crap. And so trauma is kind of the same way. And we've obviously been dealing with this pandemic trauma for quite some time, for a year now. The main sources of stress that parents report, and this is true for others as well, non-parents, mostly has to do with family members getting coronavirus, how the government is responding, a huge disruption to our routines and how things kind of go day to day. People concerned about getting coronavirus themselves, maintaining distance, and online learning for children. I have to say, those of you out there who have little ones, I don't know how you do it. I have older school-age children, so, high school. So it's easy for me to say, how are you doing in school this week? Good. Okay, good. That's great. And that's kind of all I have to do. And so I can continue to work and do all the other things that I have to do without too much disruption. But people who have those little kids at home and not knowing when they're going and when they're not. I know in our school district, every once in a while, they're like, nobody's coming to school tomorrow. What? So those kind of distractions can get to us. People concerned about basic needs. Isolation is a big traumatic event for many people. Access to healthcare, and then missing out on major milestones. So we have proms coming up, we have graduations coming up, we have lots of events like that coming up that may or may not happen. And if they do, they won't happen the way they've happened in the past. So those are kind of the additional stressors that we're dealing with right now. And I know you're all well aware of that, but these are things that most recently have come out from the APA. And one thing I always like to frame the pandemic around is the stages of grief. Because one of the things that's happening is we're all kind of grieving the life we had pre-pandemic, like what that life was like. We didn't realize how great that was in some ways. And so we're all grieving. And then, sometimes we think of those stages of grief as smooth and easy and straight, but they're not. They're much more chaotic. So that's why I like this particular diagram that shows that the stages of grief are pretty chaotic. And then what's happening with the stages of grief too, with the pandemic, a lot of times there's an event and then you start to grieve. And, for example, I'll just share with you that my grandmother at 92 years old, 92, just passed away yesterday afternoon at 2. And, that's an event. And so now the grieving really starts to take place. And that's usually how grief works. I just want to say about her that she up until 2 years ago was still canoeing with us on our annual camping trip. She reminds me of you, Nancy. I could see you there at 92 years old out there canoeing or hiking those big hills and things. But there's an event that happened. She's now passed, and so there will be grieving at this point. That's a natural process. However, what's happening in the pandemic is that there's not an event and then we can start to grieve. We're actually still in the event and grieving. We're trying to figure out how to manage that at the same time. And so I just think we want to remember that in the context of what we're thinking about today when we talk about trauma. So let's talk about what happens with trauma as far as what the numbers say. 60% of adults report abuse or other difficult family circumstances during childhood. So more than half of adults say, yeah, something kind of crazy happened when I was a kid. 26% of children in the United States will witness or experience a traumatic event before they turn 4 years old. So remember, anything you know about the brain, the developing brain is first of all very resilient and adaptable, but the younger the brain is, the harder it is to adapt to and to process things that happen. So children under 4 that are witnessing traumatic events, things like domestic violence and those types of things, that is hard on the brain. 2% of all children experience sexual assault or sexual abuse during the last year. I think that number may be a little bit low, we'll see. And 11% of girls ages 14 to 17 experienced sexual assault or sexual abuse during the last year. Additional numbers on trauma, just so we have it kind of, we recognize what we're looking at. We're not looking at just a little pocket of people. We're looking at something pretty significant. 1 in 5 children have witnessed violence in their family or their neighborhood in the last year. More than 60% of youth aged 17 and younger have been exposed to crime, violence, and abuse, either directly or indirectly. 4 of every 10 children in America say they've experienced assault during the past year, and 1 out of 10 of those children was actually injured in assault. So these are our statistics across our country, and really kind of scary. So we have to remember, and we will talk about this little by little today, but one of the things we need to recognize when we deal with trauma is we can't just wait until we know someone has had a trauma to treat them differently, to speak to them differently, or be compassionate toward them, or all those things. We need to kind of assume that everyone we run into has had some trauma, and that is expressed then in their behavior sometimes. So people who have experienced trauma are 15 times more likely to attempt suicide. And this is probably even a little higher right now because we are seeing higher rates of suicidality during this pandemic. They are 4 times more likely to become an alcoholic, 4 times more likely to develop an STD, 4 times more likely to inject drugs, 3 times more likely to use antidepressant medications, and 3 times more likely to be absent from work. So people who have experiences of trauma, there are consequences that go along for that for them. 3 times more likely to experience depression, 3 times more likely to have serious problems at work, 2.5 times more likely to smoke, and 2.5 times more likely to have financial difficulties. And then the estimated economic burden of this on our country is about $585 billion a year, which is a lot of money. So that's traumatic to our country, right? So just to show you that statistically, when we really study this, people who have experiences with trauma tend to have they tend to be complicated, like we are. So let's talk a little bit more about what specifically trauma is. So SAMHSA, which is the Substance Abuse and Mental Health, I always forget what it's for. You guys know what SAMHSA is for. They're important. They define trauma as individual trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. Sounds complicated, right? Well, trauma can be complicated. Some other more simple definitions that I often use when talking with clients is trauma is an experience or a collection of experiences that are out of the ordinary, and they cause a person to struggle to accept it and to move on. And then this is kind of my favorite over here, that trauma is really extraordinary events that happen to ordinary people, and then they cause us to kind of get stuck. So that's, when you think about the pandemic, that's an extraordinary situation, right? That's not something we're like, oh, well, one day when you experience the pandemic, this is what it'll be like. It's extraordinary. But we're all pretty run-of-the-mill normal people. And so that has the potential then to cause some trauma. When we think about trauma, it's helpful to compare it to what we see in physical wounds. So trauma is kind of like a wound of the brain. The actual Greek translation for the word trauma means wound. So we're looking at wounds kind of in the brain, so to speak. So what we know about physical wounds is they come in all shapes and sizes. So if you think about wounds that you've had, cuts that you've had, from the tiniest of paper cuts to the largest gashes of bear being mauled by a bear, I don't know. But they come in all shapes and sizes, right? When they're open, they're very visible to others. When they're closed, not so much. And they come from a variety of different things. So wounds can be caused by different things that happen to them. So different wounds affect people in different ways. So I have a client right now whose son has some wounds on his leg. Oh, he got a wound on his leg from the workplace, and he didn't get it treated, and now it's become infected, and now he has had it treated, but it's just not responding. Someone else, based on their composition of their body and whatever, may have had that treated, that infection treated, and it might have cleared right up and not been an issue. So different people respond to those physical wounds in different ways. It's the same with trauma. What might be very traumatic to me may not be so traumatic to my friend Melanie out there, who's kind of like, what's the big deal? So we want to remember that healing takes place, whether it's a physical wound or a wound in the brain, that healing takes place from the inside out. Wounds are usually obtained very quickly, but heal in time. They take time to heal. So if you think about, a cut that you get, like a paper cut, boom, it happens quick, right? But it doesn't heal as quickly as it happens. It takes longer. Same with trauma. So we experience an event or a series of events, and that trauma changes the brain chemistry quickly. Now, it takes a while then for it to process and to heal back. And then initial steps must be taken to stop the initial bleeding before healing can begin. So if you have this wound that's exposed and it's still bleeding, it's not going to start healing until that is controlled. And it's the same with these wounds that we talk about with trauma in the brain. If the trauma is continuing, then, if that bleeding is continuing, then the healing has a hard time to start. And that's a little bit of what we're experiencing in this pandemic, is that the trauma is continuing. So we haven't totally controlled the bleeding yet, and we're trying to heal at the same time. So it does slow down the process. So when we have a wound, physical or in the brain, the failure to get the proper treatment can complicate it. So like that gentleman I shared who had an injury to his leg, who did not have it treated, became infected. And that's what can happen with trauma too. If we experience a trauma and we don't process it and we don't get help to do that, if it's needed, then things get worse, right? Things get worse for us. And it expresses itself much more powerfully. Trauma, whether it is a physical trauma or an emotional trauma, can leave a variety of different types of scars. So when we see people that are dealing with trauma, it sometimes looks different for different people because they respond differently. It just depends. They might respond with anger. They might respond with depression. They may respond with lack of trust, all sorts of things, just depending on the makeup of the brain. And then the area around a healed scar is usually tougher than the rest of a person's skin. So if you've had a wound and then once it heals up, the skin just looks a little bit different, and it just has a different texture to it. And the same when we deal with emotional trauma and wounds, is that we're not the same after a trauma has happened. That's not necessarily a bad thing, but we have to remember that we're different, and the people that we work with are different, and we want to be really aware of that. So if you think about all those things of trauma, I mean, we haven't had a chance since birth, right? I mean, think about childbirth. Think about being that little cute little baby inside the womb where everything is perfect. You get fed when you want to, and you can just move around, and you're warm and comfortable all the time, and then suddenly out into the world. Pretty traumatic, right? Extraordinary event that happens to very ordinary little babies all the time. So let's talk now that we, first of all, any questions about what we've talked about so far in what trauma looks like and how we compare it to kind of physical wounds? Anyone have any comments or thoughts about that, or questions? Okay, good. So now we really want to go into the biology of what's going on in the brain when we deal with trauma. So we know kind of like what it looks like, and we kind of get the concept, but there are actual things that are happening in the brain when it comes to trauma, and we want a basic understanding of those things in order to really understand EMDR. So hopefully you can see my hand here. I can't see myself, but if you make a fist with your hand, if you tuck your thumb inside and then curl your fingers over and make a fist, then you can see the three parts of the brain that we're going to talk about. This back part here is called the R complex brain. We also call it the reptile brain. Handles our basic reflexes, our muscle control, balance, breathing, our heart rate, a lot of things that we don't have to think about that just kind of happen. We call this the reptile brain sometimes. That's why we say sometimes, you know, reptiles, no offense to anyone that has them as pets, but they're kind of boring because this is their whole brain. This is how they function. Moving up here into the middle is the limbic system. And this is where this houses the amygdala, the hypothalamus, the hippocampus. This is where we store all of our emotions, where we store memories. This is our fight or flight is in here, fight, flight, or freeze. If any of you have pets, if you have a dog or you have a cat, I bet you are confident that that dog or cat really, really loves you. And the reason you think that is because that critter has a limbic system, which means that they are capable of emotion. And that's why we see them a little different from the reptile. Then this front part of the brain is the neocortex or the cerebral cortex. The frontal lobe, handles executive functioning. So planning, organizing, writing, our rational kind of thought. So when we have an experience, what we want is for all three parts of the brain to kind of work together. So our reflexes continue to work. You know, we breathe and blink and do all, you know, our heart pumps, blood through our body. All those things happen. Plus, we can look at situations emotionally, and we can look at them rationally. That's what happens most of the time when we handle things. When there's trauma, what happens is the limbic system, that part in the middle, becomes really overactive and kind of takes over the other two parts of the brain. And so that's why trauma feels extremely emotional. You know, example I often tell people is to tell you how powerful the limbic system is. If you think about snakes, now I'm not a big fan of snakes. I would not say I have a phobia of snakes. I'm just not a big fan. And here's one of the things I think about. If there's a snake across the room from me, I'm looking across my office now. There is no snake. But if there was, then I can think to myself, you know, rationally. Like emotionally, I might think, oh my gosh, that snake is creepy. But rationally, I can think to myself, I can outrun him. And so it doesn't create a trauma. It's kind of like it's a process that the brain just works through. But people who have phobias of snakes, that concept of I can outrun that snake, or that snake is far away from me and therefore he can't hurt me, that is totally overcome by the limbic system, which just says fear, 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 fear. So it's a good example of how the brain sometimes, when there's a trauma or certain situations, does not react the way we want it to, or in the moment. And that's, again, just a natural response of how the brain works. Questions about these parts of the brain? This situation, this little thing we do with our hand is a good way to teach people about the different parts of the brain, particularly kids like it. So you can put that in your little toolbox. So now that we're familiar with kind of what parts of the brain we're dealing with, let's talk about how we really process information, because this is important to how we process trauma and deal with trauma. So our neurobiological processing system is very adaptive. It's also intrinsic and physical in nature. But the thing to remember is that we are hardwired to process things. So when you have something that happens, you can probably think of experience where you really try to figure out, how did that happen? How, you know, for example, if you're driving on the highway and you pass a car accident, you know, and the police are there and everything's attended to, and you see this car that's flipped over, you probably start to think to yourself, I wonder how that happened. You know, was he going too fast? You know, how did he get there? How did that happen? Our brains are hardwired to figure things out. And that's a natural process for us. That's why sometimes when trauma happens, it gets us stuck, because think about it, an extraordinary event that happens to an ordinary person may not have really great concrete answers to it. And so that can get us stuck kind of in a loop where we're just really trying to figure it out. When we process information, we are geared and built to integrate both the internal and the external experiences. So when we pass that accident on the side of the road, we are the way the brain is built, we are processing what we see physically and what we're experiencing physically, but we're also attaching that to some internal things, you know, a car accident that I saw before, or that maybe I was in, or I'm being mindful that I'm driving right now and that could happen to me. Or one of the things I always think is, wow, if I would have been 5 minutes earlier, maybe that would have been me. So we integrate what's happening externally and what's happening internally together. And then we store memories in our associative networks, and that helps us to develop things like perception, attitude, and behavior. So we want to remember that what is past becomes present. So what's happened to me before, it affects me today. And that is how we process information. That's a normal, how we normally process information. So we have these experiences now. We passed the car and we saw the accident, and we incorporated that externally and internally. And now we put that experience into some physically stored memories. And those physically stored memories can contribute to both our pathology and to our health. And so we have to be conscientious of that the memories actually help us to develop healthy and unhealthy ways to see the world. So when there's a trauma, there's a disruption in that normal processing system, and it actually gets in the way of the natural flow of all those things happening, and then it gets stuck. It gets really in there and stuck in a place where people can't get out of. So if you go back to that scenario about the snake, even though a person may rationally be able to say, that snake can't hurt me, that snake can't hurt me for all these reasons, he's too far away, he's dead, you know, whatever. The limbic system, because this flow of processing has been interrupted, the limbic system kind of says, nope, you're scared. And so that's going to take over everything else. And that's how trauma kind of gets lodged in there. So new experiences we have link into previously stored memories, which are those bases for interpretations of feelings, behaviors, how we see the world. So you can imagine it like a bunch of file cabinets in our brain that are just, you know, like if you saw, what's that movie, Bruce Almighty, if you saw that one where Bruce opens up the file cabinet and it just goes on forever, that's kind of what's happened in our brain, is all those things get stored. And if you think about it, the file cabinet you have in your office, you don't always remember exactly what's in there, right? You know, well, I have a file for this and I have a file for that, but you don't remember all the details that are in there. And that's kind of what happens in the brain, is those are there, but we don't always recognize them. If things are too difficult, they get stored in a special part of the brain called the implicit or the non-declarative memory. So this gets pushed down into our subconscious, or our emotional downstairs brain, we call it. So we have the file cabinets that are readily available, and then we have the file cabinets that are down in the basement because we don't need them often and we don't want to go there. And you only go down to the basement to get those files if you absolutely have to. And so we see things in that part like denial, or we see people that just don't remember certain things that happen. And that's sometimes just the disruption of processing that information and having it stored correctly. So when those types of things happen, it keeps us from storing those memories in the correct file, which affects then how we see the world. And so, you know, one of the things I always remember is not to talk about death all day today, but maybe just because my grandmother did just pass. But when my mother passed away several years ago, I remember saying, and I still say this, when she passed, like the world looked different to me after that. And I can't tell you exactly how. I mean, the sun still comes up and the sky is still blue and winter still comes. But there's just something different about how the world looked after that event happened. And I think most of you can probably experience that. If you look at things that have happened in your life, you can think about things that have happened where the world just changed. You know, having babies, I think, did that. You know, when I had my kids, you know, the world changed. But that was a more positive thing. That wasn't like a negative thing. It was a more of a positive thing. But that's the natural change and process of where the processing of our information can get disrupted. Any questions or comments or thoughts so far? Is this all kind of making sense to everyone? Okay. So we want to talk just briefly about trauma-informed care. So when you're working for organizations, this trauma-informed care becomes a very important way of how we run our organizations and our facilities so that we're conscientious about trauma. That does not mean that we have to all be trained to treat trauma. That's a little bit different. But we want people to be trauma-informed in the sense that they recognize everything that we're talking about today, recognizing that any person who presents themselves before us may have trauma, and they may not share it with us. Sometimes it's none of our business. I often say that that clients don't want to share things, and well, maybe it's just none of my business. And I want to respect that. But to be a trauma-informed care organization, we want, or clinician, we want to really be able to know what the signs and symptoms are and recognize that trauma is pretty significant in the world, and just understand a little bit about it enough so that we don't participate in the traumatization of people. And that's a really important thing. So there's six key principles which are focused on trauma-informed care. I think they're also just part of good care. So I think none of these will be new to all of you that are here today, but some of them may be a little more important than others. So safety, I think, is something we always look at, but when it comes to trauma, we have to look at safety in a number of different ways. So for example, I had a client who would come into my office who had a long history of domestic abuse and was still in a domestic abusive situation, unfortunately. And when she would come into my office, she would always lock my door. So we would be locked inside my office. Now, that's a tough one because I don't know that I like being locked inside my office. I mean, what if something weird happens? But to her, that was a physical way to really create a safe space. And so I weighed out the pros and cons, and actually it was okay. And so she would always lock the door. And my hope was one day we'll get her to the point where she feels like she doesn't have to lock the door, but we're not at that point yet. But that's safety from a physical perspective, but also from an emotional perspective. So really knowing that someone who has trauma can trust you, and that you're not going to judge what they say, and those types of things. We create that safe space for them in that way. So trustworthiness and transparency is the next one. Trustworthiness, I think, is pretty self-explanatory, but transparency is important when it comes to trauma in the sense that we don't want people to, we don't have to have experienced the same trauma that a client has in order to help them. But we also want to be very clear about that and help them understand what we can relate to and what we don't relate to, but we understand and respect. And those are really important things. Peer support is very, very helpful when it comes to trauma-informed care, and actually in a number of other areas. There's just something really healing to know that you've been through something similar than what I've been through, and so you could probably help me. There's something really powerful about that. Collaboration and mutuality. So really making sure that the client has a voice in what's happening in their therapy. Even when it comes to EMDR, I always tell clients, I want to talk to you about this technique we use called EMDR, but I want to warn you, it's sometimes when we describe it, it sounds a little hokey, but it is very well research based. So really trying to let clients, and I've had some clients say, yeah, I'm not doing that. And that's okay. We move a different direction then. So making sure that they have empowerment and choice and voice in what's happening in their treatment. And then always look at cultural, historical, and gender issues, because there is trauma related potentially to those types of issues. And there is healing that can be related as well. And so we need to be conscientious of that. So to be a trauma-informed clinician or a trauma-informed organization, you don't need to know everything about trauma. You just need to be able to focus on kind of these basics when working with people in general, assuming that kind of everybody has a trauma, because we do, right? Everybody has a story. Everybody has a story. And some people would identify it as a trauma and some people wouldn't, but everybody's got something. So how do we work with people with trauma? That's our kind of our basics of trauma. How do we work with people with trauma, and how do we, and then how does EMDR incorporate into that? So we're getting to it, I promise. But this kind of background about trauma and how the process works is important to really understanding why EMDR is effective. So we talked earlier about wounds and how wounds do heal from the inside out. But we want to remember that we need to stabilize people from the outside in. So if you have someone that comes to you that's dealing with significant trauma, then you know what's going on inside, but it may visibly be showing itself on the outside with anxiety, with substance use, with depression, with anger, with also mistrust, all sorts of things. So we need to not only work on that healing from the inside out, but we need to teach people how to kind of stabilize those outside issues so that everything can work together to get better. So if someone's dealing with substance use issues, then we need to help stabilize that from the outside so that they can get to the healing on the inside. I've often told people, some of you have heard this from me before a million times, but my original days working in drug and alcohol, I was very much a big book thumper. Don't pick up, go to meetings. Don't pick up, go to meetings. Don't pick up, go to meetings. And I still think that those are very good core principles to live by when you're dealing with substance use for most people. But what I realized in my professional journey was that we can teach people those skills, those hardcore big book thumper skills. But if we don't heal some of that trauma and damage that's on the inside, they're not able to put those skills into practice. And so that's why we need to look to heal from the inside out and also stabilize from the outside in. A lot of times what we'll see with trauma too is anxiety. We'll see people who are having panic attacks, people who can't go into certain situations. They have a startle reflex. Or certain things trigger them and then causes a significant anxiety. So we really want to teach people ways to be able to calm the body so that the head can kind of process things, so the healing can happen and can do its thing. So we teach people some of that deep breathing, teaching people meditation, teaching people, a couple of things we do is, and you can do this right now, just to give yourself a moment, but rub your hands together really, really fast, as hard as you can, till you really start to feel heat. And then you can put your hands on the forehead, on the back of the neck, or a lot of people who have significant trauma that's been physical or sexual, right over the chest. And you feel that warmth, you feel that pressure, and that can help the heart beat slower. It can help the breath slow down, and it can help the body calm. So we want to teach people like that. And when we see the EMDR demonstration later, you're going to see Jen talk about the butterfly tap, which is the main type of stimulus we use for EMDR. And we're gonna talk more about why it has some healing effects and some stabilization effects on the body. I do like to remind people that there are some actually very positive and resilient responses to trauma. So I think it's important that we remember that we deal with traumas all the time in our lives, and we don't all get stuck. And most of the time, actually, people are extremely resilient. It's one of the most powerful things about us. So oftentimes when people go through a trauma, these are some of the responses we see that are really positive. We see an increased bonding with family and the community. So recently there was a terrible incident in Ambridge, as most of you are aware, where a mother shot and killed her 2 kids. And that's a terrible, terrible, terrible thing. Some people in the community came together for a vigil, and that's one of the positive responses to trauma. And I can share too that with my grandmother passing yesterday, my father and I have become closer over the last several years, but particularly over the last couple of months in dealing with what's going on with her, because she was there in Baltimore, which is where he is, and you know, I'm obviously here, but it has created a nice bond. So there are positive things that come out of negative things that happen. Refined or increased sense of purpose and meaning. And that's a big, important thing. I often tell people, and when I write my book one day, I have the title for it already, but I remember after my mother died and I was really dealing with trauma, that was my first exposure actually to EMDR, which I'll share about later. But I kept saying to my therapist, I just think I'm broken. You know, I'm just broken. That's just it. And then one day I had like this epiphany and I said, I don't think I'm broken. I actually think I have broken open, which will be the title of my book one day. Please don't steal it. It'll be called Broken Open. But that's like a redefined, increased sense of purpose and meaning that can come from various traumas. Increased commitment to personal mission, revised priorities, increased charitable donation, charitable giving, and volunteerism. One of the things we offer at JP Counseling in conjunction with UPMC and now with Bags and Blessings is we offer a free cancer support group for survivors and family members once a month. It's the last Thursday of every month, and we hold it now at the Bridgewater Community Center in Bridgewater. And part of what developed that was after I had my experience with cancer, I just really wanted to find a way to give back. And there weren't any cancer support groups in our county. You had to go up to Cranberry and further out if you wanted to get to one. So those are the types of resilient responses that come from trauma. Trauma isn't all terrible. And most of the time we handle traumas on a almost daily basis sometimes, and we get through them. Because we are very resilient. I think that's an important thing to really remember. So I do like to talk about language a little bit when we talk about trauma, because it can be one of the most traumatizing things that people experience. If you think about stigma when it comes to substance use and mental health issues and the language that people use sometimes, it just can be very hurtful and can trigger a lot of things inside of people. So we want to be really careful about the types of language we use. And again, we don't want to be careful after we know someone has a trauma, or we don't want to wait till that point, I should say. We want to be careful with our language prior to that. When you're screening someone, it is okay to ask questions though. So we're not trying to avoid topics of trauma. We're just trying to be conscientious in our questions. So if you needed to kind of screen for some trauma issues, then you could ask questions like, have you experienced childhood physical abuse? Have you experienced sexual abuse? Have you experienced a serious accident? Have you experienced violence or threat of violence? And then these are my two favorite questions. Have there been experiences in your life that were so traumatic they left you unable to cope with day-to-day life? Or my favorite question, is there anything else significant in your life that I should know? So one of the things I learned a long time ago was that I don't always know the right questions to ask. So we can say, you know, have you ever had sexual abuse? Have you ever been exposed to serious violence? Have you ever been in a tornado? Have you, I mean, the list would go on forever and we still would miss something. Someone would still say, well, this is what happened to me. And it doesn't fit in any of those little check boxes. So that open-ended question of, is there anything else, you know, and what is that, is really, really helpful. So the example I share with that question is a gentleman I've worked with for many years now. He was a firefighter, and he came to me because of his medication-assisted treatment, and I did his therapy for him. And in their first session, we talked about his use of substances, and we talked about his history as a firefighter, and there was clearly some trauma there, and those types of things. So at the end, you know, I said, is there anything else significant about you in your life that you think I should know? And at that point, everything in his body language had changed. And he shared with me about September 12th of 2001. And on September 12th, he was one of many firefighters and first responders that went to Somerset to do the cleanup after 9/11. And he said that the first day they gave them flags, and the flags were two different colors. And one color was for plane parts and one color was for body parts. And he has described to me this vision at the end of the day when he looked back over this field and all these hundreds of thousands of colored flags. Later, they had to go out with buckets, and one bucket was for plane parts and one bucket was for body parts. His whole demeanor changed as he shared about this. And so one of the things I learned right then that kicked into gear, and I think is important for us to remember, is I had a lot of questions for him. I had a curiosity of sorts about his experience and those types of things with that, with the experience that he had. But when I watched his body language and his facial expressions change in such a dramatic way, I knew that asking those questions was not going to help him. If anything, it was just going to satisfy my curiosity, which is selfish. And as a therapist, that's not what I was there for anyway. So to really recognize that he had given me enough. He had actually given me more than enough. He could have shared that with me. He could have said, I went and did the cleanup and it was horrible. And that could have been enough. Now he decided to share some additional details with me, which I appreciated. And then at that point, I kind of said, okay, we'll definitely work that into, you know, he had some other trauma as a first responder, but that was pretty big. One of the things that he and I did when you talk from a trauma perspective, that is what we call resourcing in EMDR. It was a form of meditation. So he had a flashback often where he would start up at the sky and see this beautiful blue sky, and the tops of the trees, he said, a lot of them were still beautiful. And then as he would scan down, you'd see the burnt part of the trees and then the terribleness on the ground. And that was a reoccurring flashback that he would have. It would wake him up in the middle of the night, drenched in sweat, screaming, crying. It was a terrible thing. So we worked on what we call resourcing, and we worked on trying to change that memory. And we worked on a meditation where instead of starting from the top to the bottom, we started at the bottom and went to the top. So he would still visualize the carnage and everything he saw on the ground, and he'd go up and see the burnt parts of the trees. But the end of the vision was the tops of the trees, which were beautiful and full, and then the blue sky. And so he was able to kind of reprocess that in the brain so that when that flashback would come, his brain, he could take it a different direction. He could actually interrupt it. So it was some pretty powerful stuff. And I'm glad to say he's doing well today and still sober. So that's a good thing. But be careful of your language. That's the main lesson there. So some of the other things we want to do to help people when we're dealing with trauma is we really want to educate them. People think that they have been through situations and they should have just done better. You know, we're pretty hard on ourselves as people. And so we want to educate people that trauma is a natural, the way the brain responds to trauma is sometimes an ordinary reaction and something that we can deal with. Help people reframe their experiences that they have around hyperarousal or sleep disturbances or other physical symptoms as physiological reactions to extreme stress. So people will sometimes see those issues as a weakness, and we want to help them recognize that that's the way the body reacts to things. That's a natural response, and we can deal with that. Communicate that treatment and other wellness activities can improve both that psychological and that physiological symptoms. So I really try to help people understand that we want to heal from the inside out and stabilize from the outside in. And so there's lots of ways that work together to do that. Explain links between traumatic stress symptoms and substance use disorders, if that's appropriate. So I have a gentleman who I'm working with now who has substance use disorder, and he actually was also a first responder, different experience, but he started as a first responder at 14 years old, and he had a lot of experiences and a lot of trauma around that. And if we go back in his family, there was more and more and more. So when I look at it as a clinician, it doesn't surprise me that substance use kind of entered the picture. When we look at vets that come back and are dealing with post-traumatic stress, we see high rates of use of alcohol and other drugs. And if you think about it, if you have recurring flashbacks, if you have some sort of trauma response that is like so incredibly painful, and alcohol or some other drug takes it away for the moment, pretty sounds like something that might be helpful. So we want to help people kind of understand that. We want to normalize trauma symptoms. So really help them understand that they're not a weakness. It's not a character flaw. They're not broken or damaged. They're not going crazy. But help them really understand how things work. And then this idea of hope, I think, is most important. If you've experienced trauma yourself, or you've worked with people with trauma, then you know that sometimes they get to the point where they just think it just can't get better. And it's really important for us to remember that they can. It might not be pretty and it might not be easy, but it can happen. And so that expression of our hope to them is really, really, really important. We want to create an environment that allows the acknowledgement of the traumatic events. So I always say to people in my office, this is the sanctity of safety. So you can say whatever you need to say here. And sometimes people say, well, I don't want to say this. It's going to sound crazy, or it's going to sound mean, or it's going to sound, hey, it's you and me in this little space, and you can say whatever you need to, because those are words. And then we can process the words from there. Remember and kind of help clients understand delayed trauma responses. So when we experience a trauma, we don't always have the symptoms, the signs and symptoms of trauma exposure immediately. Sometimes it happens down the road. And so we want to just be aware of that ourselves and keep an eye on that. I had a young man recently he's 22, and about a month ago, maybe it's been even 6 weeks now, he had an experience where he connected with someone who said anyway that he was a big producer for a rap star. I don't know if he was or not, but anyway, he did have a lot of money. But he kind of in a period of, let's say, 14 hours, really started trying to groom this young man, and then made sexual advances, and the young man was able to get out of the situation, but was really just impactful to him. And so he seems to be processing through that pretty easily, and pretty well. However, it's something that even now that we're 6 weeks out, I'm still kind of keeping an eye on when he and I have sessions. And I still ask him directly about it. And I ask him if he's having any symptoms today that he thinks are related to what that experience was that happened back then. So we want to keep an eye on those delayed trauma responses to make sure that they're not happening. Make sure we help people understand the connection between past trauma and their present symptoms. And then, of course, create that safe environment. We want to explore supports and build them as we can, because it's real important that people who are dealing with trauma have good supports around them. And we may need to be the educators of their support system to help them understand the trauma response. Again, not the details necessarily, but what trauma is about. Understand their triggers and help people understand what their triggers are, and help them deal with those triggers and manage them, how to avoid them or how to deal with them if they can't avoid them. And sometimes they just can't, right? So just a reminder of things to do and not do. We don't want to re-traumatize patients. So we want to really think about our language and how we treat them and create that space of safety. Consider the role of shame and how it impacts people. So people who have experienced trauma tend to put that on ourselves. It's my fault. And that creates a lot of shame. So we want to be aware of that. Be very genuine with people, and compassionate when you can. Ask open-ended questions, which allows people to share what they want to share and not feel like they have to tell us more than they want to. Educate the client about and use the stop technique, which is something we also use when we do EMDR, which basically means that they can stop what's happening at any time. And I'll often tell clients, you know, I always think my job is to be kind and respectful. I also have to be direct and talk about things people don't like to talk about. I think I should always do that in a kind and respectful way. But you can always tell me no. I don't want to answer that. I don't want to talk about that. We're not going there. It doesn't mean that I won't bring it up again. And so I try to remind people of that. But they have the power in the moment to say, I'm not there. I'm not ready right now. And we want to be very non-judgmental. You have to remember that some of the things that people have gone through as traumas, because of the shame that's connected to them or to the trauma, is very, very, just a lot of shame connected to it. And so we have to be very conscientious that what we do is not perceived as being judgmental. I had a gentleman that we went through the whole EMDR process, and we'll talk after the break about targets and things like that specific to EMDR. I knew what his target was, but he didn't tell me the traumatic incident. And I went with that because I wanted to respect that. And then after we went through some treatment, he came back to me and he said, I want to share with you what happened to me. And he was a victim at a young age of sexual abuse by an uncle. And it was a very shameful thing to him. And so he didn't want me to know about it. He felt before he went through the treatment and had some healing, he thought that I would think less of him because this happened to him. Now, part of what happened through the treatment and the healing was he recognized that wasn't his fault. And so there would be no reason for me to judge him. Plus he and I had built some rapport by then. So then he was willing to share what the trauma was. So we have to be careful that we're not being judgmental, or that we're not being perceived as being judgmental, because that can be a little different. Help our clients recognize they're not alone in their experiences, and that trauma is, you know, the trauma response is the same for many people, even though the trauma may be different. Teach them quick affect regulation techniques, the breathing, the butterfly tap, which you'll learn later, all sorts of things like that to kind of in the moment help them stabilize from the outside in. Certainly find out what the client really needs in treatment or wants out of treatment. So one of the things that happens with trauma is we recognize the trauma, and we have an idea of how I know what will make them feel better and feel better in their life, but that may not be where they are. So we really need to be attentive to what is it that they want. I can share with them, this is my perception, but we really want to meet them where they are. And then assessing that motivation for change is always important. Okay, so here we are. Did we get to this point before the break? That is perfect. It is 10:02. So
did you happen to notice Jason's name today?
I did. Thanks for the laughs there. And I do appreciate, I did get a chance to look at the chat during the break, and some of you were sending your condolences. So I appreciate that very, very, very much. Okay, so let's move on. One of the things we want to talk about before we get into the EMDR specifics is this word abreaction, which I have to say, as a licensed professional counselor, I had never really heard until I did EMDR training. So abreaction means it's a therapeutic process of bringing forgotten or inhibited material from the unconscious into the conscious, with concurrent emotional release and discharge of tensions and anxiety. So when we use the word abreaction in EMDR, is when someone is going through the process and they have something that comes back into the brain that has been stored in that downstairs file cabinet, and it comes to the upstairs file cabinet and creates an incredible emotional outburst. And this is where people get really anxious and very emotional. You know, my first experience with EMDR, I always knew what it was as a therapist, but after my mother passed away and I had found her, I had a delayed response, and several weeks later, then I started getting this flashback of the way I found her. And I kept trying to like do the CIS thing and figure out like how it happened. And it would, I would cry like in a heartbeat. That vision would come in and I would cry, and I just could not like get myself together. So I went to see the therapist that I see from time to time. Many of you know Dick McNutt, who is a very talented therapist and very odd person. A very talented therapist though, and he said we're gonna do EMDR, and I literally cried the entire time. I mean, I abreacted I didn't know what that meant at the time, but I just was like, all kinds of stuff came up, and it was extremely emotional. And the one thing I'm very grateful about is that Dick was able to just sit there with me through that. Like, he didn't try to stop it. He didn't. It didn't seem to scare him. You know, he just kind of stayed there with me, and it was really a very healing process. But it's something we want to be prepared for when we deal with EMDR, because we just don't know how people are going to respond. And now the brain is very protective of us, so it only goes where it knows that we are able to go. It only brings up things that we're able to handle. So if someone has some downstairs brain kind of memories, and they come upstairs and come into their head, well, the brain was ready for that. Otherwise, it would have kept them down there. So that's one of the reasons why when people, if they do abreaction, it doesn't happen often, so I'm not trying to scare you, but it can happen, and we want to be prepared so that we can sit with the person through it, like Dick did with me. We want to just recognize that can happen, and kind of be prepared for it. So the EMDR is based on this adaptive information processing system, which we kind of talked about earlier, but I want to run through these kind of condensed steps. So number one is that memory targets are the basis of perceptions, attitude, and behavior. So we're going to talk about targets later because we use that as a specific piece to EMDR. So the information processing system moves disturbance to an adaptive resolution. So it gets in the way of the flow, as we talked about. Disturbing events are the primary basis of pathology. Disruption of that information processing system causes information to be unprocessed and inappropriately stored because of the way it was perceived. As the perceptions of the present link to the memory networks, various components of the previous unprocessed memories are experienced, so the past becomes the present. Accessing information allows a link between the conscious and where the information is stored, and the physical information processing system, like other body systems, is physiologically geared toward health. So we do want to remember that very last point. So even though there may be a problem with the flow of how an experience is processed, the brain is geared toward, just like the rest of the body, trying to get it to self together, which is the reason why people do sometimes have things like flashbacks or memories that come and go into their head without them thinking. You know, we used to think that flashbacks was a terrible, terrible thing. And what we've learned from studying the brain and trauma is flashbacks are actually a sign that the brain is trying to process. It's trying to figure it out. So although it does not feel good, and although there's lots of negative things that come with it, in essence, it's a good process. It's kind of like if you were a kid and you got like a small cut or something, and then it would get itchy. You know, my mom would always say, well, it's healing. That's a sign of healing. I always thought she was full of crap, but I think there's truth to that. So it's not comfortable, but it is the natural process of the body or the brain trying to get where it wants to go. So the unprocessed components or manifestations of memory can change during the processing that we do with EMDR, or if it processes in some other way on its own, to a positive resolution. Processing is metaphorically like moving down a train track. Byproducts of reprocessing include things like desensitization, insights, and changes in physical and emotional responses. So one of the things that happened after I had my first experience with EMDR with Dick, is I certainly remember everything that I experienced the day that I found my mother and the day that she died. The memory is not different, but it's not as heavy. And I can talk about it without bursting into tears. So it's become a little desensitized. There's some insights that came out of that process, and so some changes in my physical and emotional response to it. Information processing transfers information all the channels of the memory network. So that flow that was disrupted is now moving along the train tracks like it's supposed to. So I want to talk about this word processing, and I use this quote by Jamie Marich, who did my EMDR training. There's an I in her last name, M-A-R-I-C-H. I got mistakes all over the place today. But processing, she says, is just a fancy psychological term for making sense of an experience or learning. It can also include the ability to achieve the resolution needed to move on from a traumatic experience or series of experiences. Processing has been equated to digested and unsettling event. So it's kind of like the brain trying to digest and make sense of things. And that's one of the key components when we do EMDR. So Shapiro is the founder of EMDR, and she has 8 phases in her protocol, which are put into these 3 little works. So the first stage, the first 2 phases of EMDR are stabilization. And we do resourcing at that point, and we're really trying to make sure the client is ready to deal with the process. We're getting a history. We're taking a look at what the trauma has looked like for them, how it affects them in the day-to-day life that they're living now, how they perceive the trauma, and those types of things. So that's all kind of a collection of data, and then teaching the client some resources to be able to stabilize from the outside in. The second part is the exciting phases of the working phases that you're going to see in action here soon, 3 through 7, where you're working through the trauma, and you'll see how that works. And then the final stage, phase 8, is where the trauma has kind of made it through the train tracks in a smooth way, and now we want to reinforce that so that it sticks, so that there's not some sort of relapse back to old thoughts or behaviors. Shapiro had this famous walk in 1987 in the park, which is what started everything with EMDR. And what was happening with Shapiro is that she was going through a number of traumatic events herself, and she would take these walks in the park. And she recognized that when she would really start to focus on some of the traumatic events, some of the really tough stuff, that her eyes would shift back and forth at a very fast pace. And so she wondered if there was something to that. She thought that there was something healing to that. And so she started experimenting with her friends. And that's where we started initially with eye movement. We've moved on to some other stimulus. But if you look in history, the bilateral stimulation, which is key, which is the back and forth, that started with the eyes for EMDR. If you look back there in history, there's been all sorts of bilateral stimulation. The body has kind of known that this bilateral stimulation is healing for us. If you look at a history of dancing or drumming, rocking a baby when they're upset, back and forth, there's something soothing to that. Even taking a walk, go walk it off. There's a lot of things that happen, back and forth when you're walking. And so this Linda Kern said out of a book called Trauma Competency, she said bilateral stimulation is not dangerous, nor is EMDR as a modality. If it were, wouldn't it follow that we should all abreact when walking, snapping our fingers, or playing Miss Mary Mac? So there's all sorts of things that the body has in its own natural way decided this is going to help me feel a little bit better. And that bilateral stimulus is the key to what we use to move the EMDR process forward. So EMDR started with eye movement, and literally it started with 2 fingers like this, and you would follow them back and forth with your eyes. We have recognized that it doesn't have to be the eyes, it's any sort of bilateral stimulation. So we use some tactile things. We sometimes would tap on the legs if we were doing it manually. We have machines now that we have little tappers that people put in their hands, and they vibrate, so they can just sit there and feel the vibration. Sometimes when I use it with kids, I'll put them in their socks. They always think that's fun, but it's anything that you get the back and forth motion. And sometimes we even use the audio. So we also can use tones to the ears, beep, 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 back and forth. With some people, we find that we use a combination of 1, 2, or all 3 stimulus. It just depends on what works for the person. And the stimulus that we use is not necessarily based on the trauma. So someone who has more significant trauma doesn't necessarily need all three stimulus. It's just it's just the way the person's brain kind of works. We do have a couple of things we look at with eye movement, for example. Some people do say that they get not necessarily a headache, but a little bit of pain behind the eyes after they've done an EMDR session where they've used eye movement. So we kind of screen if people have a history of headaches or migraines or seizures, things like that. We just don't use it, not because it's dangerous, but because it just might be a little uncomfortable. Same if someone has like neuropathy in the hands, then we don't use the back and forth. We don't use the tappers in the hands. Or if they have hearing loss in one ear, we don't use the tones to the ears. So we just kind of screen for those things. I do see someone in the chat asked if you're going to see an example, and we will just real shortly see an example. So we always start EMDR with a target, and the target is usually pretty vague. So Jamie Marriage came up with this greatest hits list of problematic behaviors or problematic beliefs. And so these are things that sometimes if people have a hard time identifying what the target should be from this perspective, then we kind of go through this list. And if you see, they're pretty general, right? I should have known better. I should have done something. I cannot trust myself. I have to be perfect to please everyone. I cannot let things out. I'm a bad person. I deserve only bad things. Like some of us have these beliefs, right? And they're really core, and they're usually connected to the trauma. We also, when we do EMDR, we look at the first time someone had an experience. So if their target is, I cannot trust myself. Well, what's the first time you remember that you couldn't trust yourself? What's the worst time? And what's the most recent? Those are some of the things we look back. What we're trying to get through in that processing, we looked at how that works in the brain, is we're trying to get them from those greatest hits of negative beliefs to this greatest hits of positive beliefs. So I did the best I could. I can trust myself. I'm in control. I'm good enough. I'm a good person. We're trying to get them to those types of greatest hits of positive beliefs. Okay, so this is, let me check where we are at time. Perfect. Okay. So what you're going to see next that Jen's going to bring up for us in just a second is a demonstration. And if any of you know Jen Oakes, I used Nicolas Cage in this little meme here because Jen has the perfect Nicolas Cage face, especially when I hired her as her first therapist position many, many years ago. She'd be a great poker player, I can tell you that. Jen does virtual EMDR, which, as I've said, I do not. I still do EMDR in person. I just have not taken the time to get really comfortable doing it virtually. But Jen has, and she's going to talk to you a little bit about some of the really great things that have come out of that. And then we're going to do a demonstration. And so I'm not going to set that up anymore, except to say this. Jen is the facilitator. I am the patient. And I think I say this in this video clip that you're going to see, but I don't remember. So if in case I don't, I want to say it now. What you're going to see is a very real example of what EMDR looks like. But also just remember that there are a couple things that set it up that make it not perfectly genuine. So for example, the target we're looking at is very real. I've never worked on, Jen and I didn't stage this. It's not scripted out. It's just what actually happens. However, before we get into the demonstration is, thank you. I have only ever done EMDR in person. When we went telehealth last year with the pandemic, Jen stepped up, as did our other therapists here who do EMDR, to make sure they were competent and figure out how to do EMDR virtually, which is done, but I didn't do that. So I still only do EMDR in person. I'm a slacker. But Jen, can you tell us a little bit about your experience of doing EMDR virtually versus in person?
Sure. It was a little overwhelming to think about how are we going to really get the bilateral movement piece virtually. And so I attended some trainings with EMDR, and through some studying, they really found some good techniques to be able to have bilateral movement while you're meeting with someone virtually. The biggest issue is because when you do get trained, you are going to learn different speeds of bilateral movements, and the importance of what speed to use when actually is important. So that was one of the biggest things, is how do we really kind of control the speed of the bilateral movement? There are some nice programs out there where actually you and the client can share a computer screen, and it's a dot that's moving back and forth on the screen that you can control as the therapist. I personally don't like it. I have found enough success with the bilateral movement that I use is called a butterfly tap. All you do, you kind of link your arm or your thumbs together. You put it up, and your top of your fingertips really just want to be on your collarbone. Your fingers need to kind of be pointing up a little bit, and boom, you just have the client go back and forth. 1, 2, 3, 4. And you kind of give them the speed at the beginning of kind of how you want to work through. So I will admit, I was a little hesitant to begin this process. I had several clients right at the start of pandemic that I was moving into the reprocessing phases 3 through 7. And I just did not want to stop the wonderful progress that we were doing. So I actually moved into last year after getting some training with virtual EMDR, and I've had a huge amount of success. In fact, there was a big therapist forum for us as EMDR therapists that was doing it virtually. We couldn't understand what was happening because people were so successful in lowering what we call it. It's called a SUDS. Well, you'll probably hear me say that with Jill when we do our demonstration. The level of response was quickly happening. And what we have started to decide was it the comfort of your own home? Was it the fact that you could really be in that memory and feeling comfortable? And so the reprocessing just started to naturally happen so much more. There's not a full study of why this is being so successful virtually, but people are actually moving much quicker, reprocessing for some reason with the virtual. So we've seen a lot of success with bilateral movement happening virtually with the phases 3 through 7. So one of my favorites is I had a girl, and we were just getting ready to do reprocessing. We shut down the offices. She was a little concerned about doing it online. And I said, let's give it a shot. Worst we can do is we can at least try it. We'll get back into the office at some point and try it. And what she was having, there was a sexual abuse, sexual assault, lots of abuse from a prior relationship. And she has done lots of cognitive behavioral therapy. She was still having terrible, terrible, terrible nightmares. So we started the process. We moved into phases 3 through 7. We probably maybe only did 3 or 4 reprocessing sessions within a month. Her nightmares almost literally went away. Funniest thing, her worst fear was somebody was going to break into her home. She lived alone with her child. And wouldn't you know it, some little 8-year-old kid broke into her home. And I thought, oh my gosh, we're going to be so set back. And we actually did a reprocessing session right after that happened. And it was amazing. She could still stay home alone. She felt empowered, and it was just such a miracle to watch. And I was so grateful that she allowed me that opportunity to work with her.
Yeah, I think and to help people understand like what things we use EMDR for, I've used EMDR. One of the most interesting cases I had, and it was quick, bing, bam, boom, was I had a little girl who had to take medication through an IV once a month for a chronic disease. And she took it the first 3 times and had no problems. And then the 4th time, she had an allergic reaction to it. And so she was in the doctor's office getting the IV, but her mom and the nurse were like chatting. And so her throat was swelling, closed, and she was trying to like get them, but she didn't have a voice, and then when they finally realized what was going on, they took care of it. Well, they changed her to a different medicine that actually her mother could give her the injection at home. And she was terrified to take it, terrified. And so we did a few sessions of EMDR to help her kind of process through that. And she pretty quickly was then able to It was all about her voice. Her target was about, I lost my voice. No one could help me because I could not, I had no voice. And so we targeted through that. And within just a short period of time, she was able to take that medication, which was really a great thing. So sometimes we use it for small things like that. I have another gentleman that I'm still working with now. I call him my rock star because he is a rock star, at least in his own mind. But he has a very, very complex trauma, starting from being a little boy and having a number of surgeries that he doesn't even remember, but he knows he had them as a child, as a baby. He was an EMT, coming from a family of EMTs, seen lots of people die, lots of people he couldn't save, and those types of things, and just lots of complex trauma. So he and I use EMDR over the long haul. So what are some examples? You gave the example. I love that. I remember her when you told me that that little boy broke and tried to bring it around.
Yeah.
I was like, what are the chances? What are the odds?
One of my most powerful EMDR experiences was with a woman in the Vegas shooting. She was actually at the concert when the shooting started to happen. And so that's a large, what we call big trauma.
Mhm.
I've had a car accident where she had some ankle issues, and I've gone as far as there was a woman who she was afraid to have a baby. She couldn't quite understand what was going on, and we kind of worked through that, and we found some target memories for that helped her kind of get over that. I heard you use the word stuck, where they kind of become stuck a little bit. In fact, she was just in session with me the other day, burping her little baby, and I just thought, wow, what a miracle, you know. But so yeah, we use it for big T's and small T's all the time,
Have
which is
you,
nice.
Jen, ever offered EMDR to someone who said, no, I don't think so?
I did. Yes, I did have a client. He it just wasn't for him. He didn't feel comfortable with it, and we let it go. He was a fireman. He had a lot of big T traumas, a lot of car accident scenes that he responded to, and he just felt like he couldn't stay in the moment. He just couldn't be in there, and so I moved around it. It wasn't something I forced. So, and I don't know if you said this, with EMDR, there are some therapists that do EMDR only. That's their only track. But if you guys, there's a site called Emdr. It's the organization that oversees EMDR. There's actually a little piece on there that talks about how you can use this in conjunction with regular talk therapy. And that's how I kind of use it. I will use it. It's a tool. It's one of my theories that I will go to, but it's not something I use. And I won't kick a client out, of course,
Right.
that doesn't want EMDR. But over the couple years that I've been doing it, I've only actually had one that we tried to do some of it, just wasn't up his alley, and so we just moved away from it.
Yeah. I've had a few times when I brought it up and someone would say, well, I have one woman right now who's considering it, but she's not quite sure. And I'm like, that's okay. And the great thing about it, and we can say this to you guys here too, is there are a number of YouTube videos. Like there's a lot of stuff out there that you can study up on EMDR and you can watch it. And I encourage clients to do that if they're like, this sounds weird. Like, I know, but it's really been validated. And so here's some ways you can kind of check that out. So I think that's okay. So what we're going to do today, ladies and gentlemen, is we're going to do a demonstration of EMDR, and I asked Jen to do it primarily because she does it virtually, and like I said, I don't, and I wanted to make sure that we give you a good demonstration. And so I agreed to be the victim here, or kidding, the client here. And so what you're going to see is I'm just going to be real honest. It's going to be real and not real at the same time, if that makes sense. So you're really going to see the process. Jen and I are going to talk about a real issue, a real target of mine. But I also want you to know, like, I obviously, because I'm here with all you guys today, did not pick my deepest, darkest secret to work on in this 10 minutes with Jen, live in front of everyone. And Jen,
thank you for that.
Yes. So Jen has my back. So if I abreact or if things get too deep, she's going to take care of me and make sure I don't have to embarrass myself in front of everyone. And then I also, because I understand the process, have some ability to do that as well. So, but it will give you a good idea, a good way to see the process and see if it's something that you're interested in. So with that, Jen, I'm going to turn it over to you.
Sure. Thank you.
And we did not go over things like SUDS. So when you talk about things like that, if you could just spell it out for them.
Perfect. Okay. Just a couple notes. Usually when I do virtual, I do ask my clients to put on headphones. One of the things that with virtual, and it seems to really work, when just all they see is or hear is just the therapist in your ears, it's a lot easier to really stay in that memory that you're just hearing my prompts with that. So that is one recommendation that we've made too, is using headphones to be in the client's ears to really hear my directives with that. The other thing I want you guys to note, you're going to hear a lot of silence. I heard Jill mention earlier about re-traumatizing. That's one of the things about EMDR is you don't have to actually force the client to say much of anything. So don't be surprised when you see me sitting here in silence several times, as well as Jill. Some people aren't comfortable with silence, but this is actually when the reprocessing is happening, is actually when the client is quiet. So you're going to see lots of breaks there. Know that when that's happening, what I'm doing on my side, I'm actually counting. There's things I'm watching for, and I'm virtually, looking at the client, and I'm going to be actually counting. That's the one thing is when you have this, you actually have to see the client's hands. And that's why I like this one and not tapping of the legs, because you really can't count when someone's down below. So Jill, I'm actually going to have you sit back a little bit just so I can see your hands up there. Okay. And I'm going to ask you to lock your thumbs there a little. There you go. And just put them on in there. So Jill, what I want you to do, first of all, close your eyes for me and just take a deep breath in and blow that out. And I want you to think about, we had a conversation that recently there may be some anxiety going around dinner times over meal planning. You remember this? I want you to think about a most recent memory that you've had that explained, kind of represented the anxiety you were having over meals. Do you have a memory that comes up in your mind?
So the memory I have actually just last night. So on Thursday nights is the only night of the week that I'm responsible to feed everyone in the family. And it gets me anxious because I just don't know what to do. I don't know how to accommodate everyone. And someone's always going to complain that something's wrong, and that like just stays in my head. And so it's very difficult for me to figure out what to do.
Okay.
So then I end up just ordering out.
Okay. So tell me, when you think about this memory, especially from last night, what's the image, what's the worst image that comes up with that?
It's somebody being disappointed.
And do you have something that represents it?
That's a tough one. Like I can see their faces.
Their faces. Okay.
Yeah. Because someone's always disappointed. So it's that. Oh, okay.
Okay.
Look on their face.
And tell me, when you think about this memory and you see the faces, what's the negative cognition that comes up for you? I am not.
Yeah, I just can't handle this. I'm not good at this.
I can't handle this.
Yeah, I can't handle this. I can't. It's really more, Jen, like I can't make everybody happy.
And when you think of a positive cognition, the idea that you would like to replace that with, what would you like to say?
I would like to say that even though I can't make everybody happy, I can still do a good job.
I can still do a good job. Just FYI there, I want you guys to know that what I'm doing right here is called like the light up session. What I'm doing is kind of lighten her up to get her into the memory. And we do this, it's called TICES. There's a certain categories that you have to hit. Right now, I just hit her cognitive side. I looked at negative cognition and positive cognition. All right, Joe, I'm going to pull you back there a little bit. talking about this idea, I can't make everyone happy. You'd like to say, I am still good. On a scale of 1 to 7, 7 believing you absolutely believe you can still do good in this moment. Where are you on that scale of 1 to 7?
7 is the highest, like a 3.
And when you think about this image too, you see their faces when you're talking about dinner. What's the emotions that start to come up for you?
Just vulnerability and just not being good enough.
Vulnerable,
Yeah,
feeling a bit
failure.
insecure.
Yeah, insecure, failure.
And when you think about this memory here, when you think about seeing their faces, on a scale of 1 to 10, what's the level of disturbance that you feel when you think about this?
Like an 8.
An 8, okay. And where do you feel that in your body? Where's that located, that discomfort that you're feeling there?
Mostly in my stomach, a little bit in my chest, and mostly in my stomach.
In your stomach. Okay, just to pause there to let you guys know what I worked there was cognition, and then I moved to the emotional side, and then I moved into the physical side. So I'm lighting up all senses in her body there with the cognition, with the emotion and the body sensations, okay? Now I'm going to actually move into what we call phase 4, desensitizing. So Jill, I want you to think about this memory, okay? I want you to think about last night, telling the family it's time for dinner, and you see their faces, and you start to think, I can't make everybody happy. Feeling that level of vulnerable and anxiety, feel it in your stomach. I want you to go ahead and start tapping for me. Okay, take a breath. Tell me what you're noticing.
I'm getting a little angry.
Angry. Go with that. Go ahead and tap. Okay, take a breath. What are you getting?
I was thinking about other nights when Bill makes dinner and somebody's not satisfied, and it's not an issue. They just get something else on their own. I mean, they're not babies.
Okay, go with that. Go ahead and tap. Okay, what are you getting?
Well, I noticed that feeling in my stomach is moving up further into my chest.
Go ahead and go with that. Start tapping. Oh, okay. What are you noticing?
More anger. I just feel like the family sometimes doesn't respect my time or my efforts.
Okay, go with that. Tap. Okay, take a breath. What are you noticing?
I just really want them all to be happy. You know, I love them all so much, but I guess, one dinner does not define our whole relationships.
Go with that. Tap. Okay, take a breath. What are you getting?
You know, I think the issue is not so much about me not being able to make dinner to satisfy everyone, but about how they handle it when they're not satisfied, when they don't get what they want.
Go ahead and tap. Take a breath. And what are you noticing?
Well, you know, a lot of it is about the youngest. They're 17 years old. They're going to be 18 later this year. And I really don't have to take care of them anymore. And that is a struggle for me.
Go ahead and tap. Take a breath. What are you noticing?
It's just not about that dinner at all. It's just about my babies growing up.
Go ahead and go with that. Take a breath. When you think about that original image, when you think about their face, on a scale of 1 to 10, how disturbed are you when you see their face now?
More like a 3.
Okay. Go with that. Go ahead and tap. Take a deep breath. Blow that out. Now what I want you to do is I want you to just picture a light over your head. Can you see it?
Mm-hmm.
What color is it?
It's like a pale yellow.
Okay. Go ahead and tap more slowly for me. Tap 1, 2, 3, 4. Okay, take a breath. And I just want you to envision this light entering your body. You feel its warmth and giving you strength. Go ahead and slow tap for me. Okay, and see this light go all through your body, giving you your strength that you need to feel empowered today. Taking anxieties away. And pull that light. You can push it back up to above your head. And know that it's there when you need it. Take a breath for me. And when you want to, go ahead and open your eyes for me.
That did not go where I expected.
You're right.
Okay. So one of the other reasons, I'm a little tearful, there we go. Okay. One of the other reasons I thought that I would do this part of the demonstration with Jen is when I have done EMDR before, I usually get someplace pretty quickly. So I expected this to go more in the sense of anxiety and whatnot. I did not expect it to go to transition of my babies growing into adults. Oh my gosh.
So amazing.
Okay.
Just a quick note I'd like to share with the audience. I don't know if you guys caught it, but what I was looking for there is what we call the, I can't even never say that word, but it's the actual shift. So I'm looking for that whole time I'm in there watching to make sure her brain's in it. Jill is well versed in this. Sometimes clients pull out of the memory. It's too scary. They don't want to touch it. So there's other things, the way I got to pull patients to make sure they're staying in that memory. That whole time Jill's brain was working, and what we're taught is just stay out of the way. Let her brain needs to go where it needs to go. And so I saw that shift happening. That's why I didn't do a lot of what we call interventions there. But that was kind of the simple. You have them tap, you say, what are you getting? And then you say, go with that. And that's kind of the process. But there's a lot of things, even though it looks like I'm not doing anything, there's a lot of things I'm actually watching for during a process session like that.
Excellent. Thank you. Well, that's hard to watch when you're the person there doing it. So hopefully that gave you guys a really good view of what it looks like. You know, I think the biggest transition going from a regular therapist to doing EMDR is like Jen said, you really kind of stay out of the way a lot. So there's not as much talking when you're in the process. Now, one of the things I love about EMDR is it gives you lots of stuff to talk about. So that's a good thing. A couple of last minute things. I'm going to run through these really quickly because we are tight on time and I want to make sure we can answer any questions if you have any. But just be aware that when we're dealing with trauma, there are some occupational risks for all of us. That's just part of the ballgame, part of what we signed up for. Even Mother Teresa understood compassion fatigue, and she wanted all of her superiors, or she wanted all of her nuns to take an entire year off every 4 to 5 years to allow them to heal from the effects of their caregiving work. Wouldn't that be great if we could take a year off every 4 or 5 years? But it's an important thing. So remember that hope does not take away your problems. It can lift you above them. So it's a really important thing by our friend there, Maya Angelou. So hopefully this really helped you get a good understanding. I want to check in. Does anybody have any questions or comments? You're welcome to put it in the chat, or you could unmute yourself if you wanted to add something. Quiet group, which is okay.
Hey, Jill.
Yes.
I just wanted to say thank you. I've been very interested, as you know, we've had this in previous conversations, in the EMDR experience. And this is very, very insightful. It's given me a lot of information that maybe I'll take back to my therapist because she wants to do some EMDR work with me. And I've been like, I don't know. But thank you for doing this. It's so informative and I really appreciate it.
Well, you're more than welcome. And I would highly encourage it. And remember that, like with any other therapy, you know, if it gets uncomfortable, you just stop. You just say, I'm not doing this anymore. And then that's okay. But yeah, if you're a therapist that you trust, then that's the best place to go and to start it. If any of you are interested in pursuing EMDR training for yourselves, then you can check out the Emdr website, which Jen referred to. It's EMDRIA. That's the International Association of EMDR. And they will give you training resources across the country. And I went to beautiful downtown Cleveland when I did mine, but sometimes they have really great trainings in Hawaii and really exotic, beautiful places. So check that out.
You had me in Hawaii, Jill.
What's that?
You had me at Hawaii.
I had you in Hawaii. So also Jamie Merritt and the Institute for Creative Mindfulness in Ohio does some really great trainings. We hosted them to come out here last year. So some people got trained in the area. Jamie Merritt also has a book called EMDR Made Simple, which I referenced in the training. One of the things that's good about EMDR too is you don't have to go through the 80 hours of training to be able to do some of the EMDR techniques. So you could read up some of those books and those types of things. So great comments that I'm seeing in the chat. I did see someone ask about Medicare or Medicaid, I forget which, but at JP Counseling at this time, we don't take either. We are in the process of getting credentialed to take Medicare. And primarily because we have a really great therapist, Linda, who does EMDR here with us, who only likes to work with people over 40. And she really likes working with the older population. So we're working on ways, because we get a lot of patients that call that would be a good fit for her, but we can't take them because we don't take that Medicare. But we are not in the process of taking Medicaid at this time. We do have a sliding scale for clients, and we do offer some free care. So if you're interested or there's someone that needs something, please feel free to reach out.